A very good morning to all of you. So the title of my presentation today is Patient-Centric Care. So I'll just start with screen sharing. So as I said, for some time, I'm going to talk about patient-centric care. So I will start with sharing the story of a patient and to see what it means when we say patient-centered care, and especially from patient's point of view, what it means when you say patient-centric care. So this is a story of a 68-year-old gentleman with advanced COPD. He was brought to the hospital with severe breathlessness. Patient was shifted to ICU. He became extremely restless and they had to physically restrain him. Soon the arterial saturation began to fall and the resident decided to put him on artificial ventilation. 2 days later, he passed away. It was obvious to the doctor that he was likely to die. Not obvious to the patient because he had been in and out of the hospital many times in the past. The family became very angry. I'm sure many of you relate to this situation because it's quite common how often the family gets very upset about some unforeseen sudden events. So what really went wrong here, or what was not so good about the way it was, what was happening? So we have to ask this question. Some problems I see which probably would have happened here is that probably the patient, if you look at the patient, how patient finally died and how good was his end of life care. Obviously, he was very dyspneic. He became very restless. Physically, he became very agitated. Probably he was having delirium and they had physically restrained him. And for his end of life care for an elderly gentleman with advanced cancer lung, he was put on ventilation. So obviously symptoms were not very well managed. What about his death, the final event of death? What happened to him? He died in isolation. He could not say final goodbye to his family. He was away from his family all alone at the time of dying. Obviously, there was no preparation. It was quite turn of events. A lot of things happened one after another and he just died. There was obviously no preparation. Was it really dignified, the death that happened to him? It's something debatable. What was the rationale of mechanical ventilation in this kind of situation? Advanced cancer, both the lungs, advanced COPD, both the lungs badly damaged. We know that in advanced COPD, elderly gentlemen, the rationale of mechanical ventilation is very debatable. What about his psychosocial and spiritual support? Was it adequately addressed before he died? And what about his family who was waiting outside anxiously, hoping that their loved one would come back again? And so was it all right, the way that the events happened? So how much we could support the family in this whole care plan? So how things influence a care plan, when we talk about making a care plan for a patient having some kind of health issue, often the care plan is influenced by patient's values and beliefs. What patient would like to have for his illness, for his sickness, what is that patient would like to have? You must have seen many patients, they prefer to go for alternative treatment or system of medicine for their care. So it all depends on their values and beliefs. When they reach a hospital, the patient's care plan is heavily influenced by physician's perspective, physician's values and beliefs. It may even have some biases, but often it is also guided by physician's best practice, which is based on evidence-based medicine, which the physician learns in his medicine. So that is heavily influencing patient's care plan. In addition to that, the patient's care plan is very much influenced by societal perspective, how the society sees, expectation of a society when somebody is falling sick, and also it depends on how much of resources the community can spare for the care of such patient or sickness. the racial, ethnic, socioeconomic influences and disparity. A lot of things play very heavy influence on finally how a patient gets care when the patient is sick. Patient-centric care can be defined as, one of the definitions, providing care that is respectful of and responsive to individual patients' preference, needs, and values, so as to ensure that patients' values guide all the clinical decision. That is what is patient-centric care. It's all about patient's values, needs, preferences. So all the clinical decision, all the care plans should be guided by that. And it is collaborative and respectful partnership between the service provider and the user. Most of our hospitals it works on business model. So many times these aspects of patient care plan gets compromised because it's heavily again influenced by our business plan, and so it's more about profits, and many times it gets compromised. Even in public hospital, government hospital, necessarily it doesn't happen like the way it is being described. What does a patient want? A patient, when a patient is sick and what is it he's looking for when he's approaching a health system? He's looking at his quality of life, mobility, ability to carry out certain tasks, ability to focus, quickly return to work. He's very worried about side effects, risk of treatment. He's worried about his symptoms. He's worried about his survival. But each patient may have each outcome, but these are a few things which bothers him when he's going to a hospital. The studies have found that when a care plan is made, which is patient-centric, any hospital, when you're focusing on patient-centered care, outcome, what is the outcome? They found that when you go by this way of looking at patients, it improves satisfaction among patients and families. It enhances the reputation of providers among healthcare consumers. Very often, certain hospitals, some physicians, they become more popular. And one of the reasons why they become more popular is because very often, if you really study deeper into what's happening there, success lies on if it is patient-centric care. There's a better morale and productivity among staff. Staff feel good about it. When the patient is satisfied and the care is according to the patient happening, very often we feel good about it. When you do patient-centric care, very often we forego many of the treatment which we are doing in a form of defense, because we have to do it, otherwise I'll be legally bound, and that's the reason many treatment which we do are often not required, or often it is futile treatment, still we keep on doing it, and that leads to a lot of unnecessary resource utilization. So it says that when you do patient-centric care, very often we don't have to do all that, and it leads to improved resource allocation, and it also reduces reduced expenses and increased financial margin throughout the continuum of care. So these are the outcomes which they describe when you talk about patient-centric care. The reason we're talking about this in this forum is that because there's a gradual shift globally. There's a systemic shift in thinking about empowering patients to take an active role in their care plan. The more and more people are talking about how patient decides how they want their care to be. They decide. I've just taken one example, how people are talking about different principles when you talk about principles of patient-centric care, how it was introduced by Picker's 8 principles of patient-centric care. They talk about these 8 principles. We'll quickly go into each of these to understand what it means when you talk about patient-centric care. The first is the respect for patients' values, preferences, and expressed needs. Here, involving patient in decision-making. The core essence of this is involve patient in decision-making based on his values, preferences, and expressed needs. recognizing that they are individuals with their own values and preferences. It is my body. I will decide how I should be treated, how my body should be handled in the event of things going wrong, or if I need treatment, if I'm coming to a hospital. Treating the patient with dignity, respect, and sensitivity based on, again, his cultural values and autonomy. So there's a lot of shift. The modern, if you look at the curriculum change, how the curriculum is these days framed about medical curriculum or nursing curriculum, they're giving a lot of emphasis on cultural competency, because when you are aware of, when you're competent, you have this competency, you look at all these aspects when you're planning a care plan for patients, and the patient come to you in a hospital. I want to just talk about, because here you're talking about the patient deciding about the care they want. Let's look at the typical doctor-patient dynamic when a decision is being made. We say doctor-patient communication. I'll give you 3 models of doctor-patient communication and decision-making, and you see what is the most common thing which is practiced in our regular hospital setup, and which is one you would like to have it for yourself, and which is the one you would say the best kind of doctor-patient communication. So let's look at these 3 models. First one is, we call it as paternalistic model. Paternalistic means that here the relationship is something like father-child. So we call it as paternalistic. The doctor as an expert gives information. The patient and the family passively receives information, and the doctor makes a decision. You tell the patient, hey, this is advanced cancer. You got cancer in the stomach, which is quite advanced, but maybe if I do surgery, let me see how much I can take it out, and there may be some chance that we can reduce the progression of the disease. Patient and the family receives it, and the doctor says, okay, come tomorrow, we'll start with the workup for your surgery. That is a paternalistic model, one of the model. The second model we talk about is informed or consumer model. We see a lot these days, more and more we are seeing this kind of model, where doctor as an expert gives information, the patient and the family receives information, sometimes they challenge doctor's authority, and finally patient decides how his care he wants it to be. For example, the same situation, cancer stomach, doctor gives the information, it's advanced cancer stomach, but maybe surgery may be helpful. The doctor and the patient and the family says, no, but I have somebody in my relatives living in US, and he told me that probably the chemotherapy would be a better choice. Let me go back and understand what is happening. I'll speak to them and come back to you. Or they will go online, Google, and look at the evidences and look at what information they have there. And finally, patient comes back and says, doctor, I think I would rather go for chemotherapy. I don't want this surgery for my treatment. So this is what we call informed or consumer model. The third model, we call it as collaborative or mutuality or partnership model. Here, doctor as expert in medicine gives the information. Patient is expert about deciding about himself or herself, receives the information. There's a negotiation, and finally shared decision making. So same situation, advanced cancer stomach, doctor gives the information, patient receives the information. He will say, okay, doctor, what are the pros and cons if I undergo surgery? What if I just take the chemotherapy, and what will be the impact of that on my quality of life? Because if it is advanced, I don't want to undergoing so much of invasive procedures, because I just want to be, if there's any way you can just control my disease. So there's a negotiation, and finally doctor and the patient together make a shared decision. So these are 3 models: paternalistic, informed consumer model, and third is partnership. I think the most hospitals, the model which is followed is paternalistic model. And that's where there's a conflict happens, because the doctor decides, very often the patient is not in the loop, or the family also, maybe the information shared is not done adequately very often. Even the doctor feel I share the information, the family doesn't get it, and the patient also kept totally out of, they don't know what is happening, and the decision is being made, and that leads to a lot of unhappiness and conflict. Many people, today's life, they like to have consumer model where I decide for myself. They say the best model is partnership model, where the both doctor and the patient together make a shared decision making, and that is what is more and more the consensus is tilting towards this, and which is an integral part of patient-centric care. The second component of patient-centered care is coordination and integration of care. Patients, when they come to a hospital, often they feel very vulnerable and powerless in the face of illness. So if you can gently help them for the seamless care coordination, this can be the coordination of clinical care. When you say, hey, now tomorrow I'm doing the surgery, go to room number 34, get the investigation done. After that, you go to anesthetic checkup. There's that is in the top floor of the building. And after that, you come back to me next week. When you say all that, they feel so anxious and vulnerable, and they don't know, because it's a strange place, strange people, and you feel lost. So if you have a seamless care coordination within the clinical team, it helps. It's so helpful for the patient. And the coordination of ancillary and support services. You need to undergo to Department of Physiotherapy to get your braces done for your back, and then also you need to go to the investigation labs and get your report collected. So all these things, when you talk about all these things, it is much more seamless, much more patient friendly. It gives so much, they feel so much helped. This is what we call coordination and integration of care. Information and education. They are often they express that they were not completely informed about the condition or prognosis. This is the core thing which we keep hearing again and again whenever we hear about the conflict within the hospital, between the hospital system and the patient. Hospital feels I conveyed everything. Yesterday only I told everything, but the patient feels no, it was not conveyed. I thought it meant something different. So more and more people talk about adequate information sharing and education. Now this can happen only if the health professionals undergo specialized training in how to share information. Because very often when we do our medical graduation or nursing graduation, we are not taught about this. We are not taught how to share information, how to communicate with the patient and the family. So these things are not taught, and often that leads to very inadequate sharing of information. So this information can be shared about the clinical status, progress of the disease and the prognosis. Information on process of care, what is that it means when I say radiation? We say, typically I work in Hyderabad and I hear how the information is shared. We say for radiation, we say current shot lagana. Current shot may mean many things to the patient. So it's how you tell them what it means when we say radiation or a current shot. Similarly, information to facilitate autonomy, self-care, health promotion. All these aspects also means how you communicate and what the patient finally gets it here. It all needs little more training we all need as a health professionals. The fourth component is physical comfort. It means a lot to the patient. They don't care if you say, it's stage 2 cancer and I did that, the high technology intervention in terms of radiation and the surgery was perfect. It doesn't mean to the patient anything. For them, during that period, how much they suffer in terms of their pain, their physical discomfort, nausea, vomiting, simple things like constipation. If they have constipation and that is not addressed, they feel miserable, and they leave the hospital and go away just because of that one particular reason, that the physical comforts were not addressed. So when you talk about physical comfort, the most important part is pain management. Pain is one of the most frequent reason why any person seeks medical advice. And when that is not addressed, anyway cancer treatment is happening. Once the treatment is over, anyway pain will come down. If you take that stand, you may lose your patient. Patient will decide to leave, just not come back to you. So aggressive assessment and treatment of pain is one important critical component of any patient care. Then their physical comfort also means assistance with the activities and daily living needs, and physical comfort in terms of how patient friendly the hospital surrounding and environment is. So when you send them for different investigations, the patient movement within the hospital, it all needs to be patient friendly. If not, they don't feel good about it. Emotional support, alleviation of fear and anxiety. Mental health plays a very important role how a patient feels good about everything. You may hear a lot of incidences where the patients, even though you are thinking that you're giving best of treatment, the best technology and best treatment, patient may choose to leave you and go to that one Baba sitting under a tree giving vibhuti or some jari booty. The patient prefer to go there. Why? Because very often that Baba sitting under a tree, we often in the hospital, what we do is we see the patient through the prism of a technology, CT scan and MRI. That Baba under this tree, he may just touch the patient and say, let me see how I can help you. I'll take care of your suffering. I am there for you. And that means more to the patient than that CT scan or MRI. Because they have a lot of fear, anxiety, which comes with any prolonged illnesses, and especially when it is very debilitating illness. The anxiety over the physical status, treatment, prognosis. When I see many patients receiving radiation for their treatment, and during the period of radiation, they develop severe mucositis. It can be very painful. They can't eat and they feel very tired, feel severe pain, and they feel miserable. And they say, enough. I can't finish the treatment, and they just decide to go home. And in the process, they don't finish the treatment and the cancer recurs. This is simply because nobody is talking to them about what is happening to them, why this mucositis. If somebody just explained to them, hey, mucositis is a very temporary thing. I'll take care of your pain. You don't suffer, but this is a side effect of treatment. But when you finish your treatment, you have to finish your treatment, because when you finish, your cancer will get cured. This explanation goes a long way in alleviating their fear and anxiety. Anxiety over the impact of illness on themselves and the family. Nobody is talking to them about what they are undergoing because of this illness, and for having stayed in this hospital for the last 6 weeks, they have been in this hospital. What's the impact of that on their family and for themselves? Financial impact. It plays a very important role in our population. The finance of the whole treatment and their stay in the hospital. The sixth component is involvement of family and friends in patient experience. In our culture, patient and the family, they function as a unit. We cannot see them separate from the family. Even though we speak a lot about more and more the discussion around patient's autonomy, but family is very important in the whole care plan. So how much we involve the family in decision making, or making the family feel comfortable in the hospital, recognizing their needs and supporting family members as caregivers plays a very important role. Classic example is we say, okay, patient develops stroke, paralysis. After the initial treatment, we put the Ryle's tube, we put the catheter, and we tell the family, now you take him home and take care of him. Nobody teaches them, okay, what to do when they go home. Patient is still paralyzed, he can't move. How to help the family to take care of such kind of patient with their Ryle's tube, their urinary catheter, totally paralyzed, what kind of exercise, what kind of rehabilitation they need. If only if somebody guides them properly, even if you go home, this is what you need to do, and we are there to help you to support your family patient. It goes a long way helping the family, and they feel so satisfied. The seventh component is continuity and transition. Patient often expresses concern about their ability to care for themselves after discharge. So when you meet patients, this particular need, they feel satisfied. The same example, the stroke patient, when he goes home, how to take care of, continue to take care of that patient in the home setting. So that's very important role in the overall care plan. Understandable, detailed information regarding medications. So too many medicines. When they go home, they go with this one huge packet. Often they feel so confused, yellow tablet, blue tablet. Even educated patients, they get totally confused about whether to take before food, after food, how many tablets can I take in the night, too many tablets, why do I need this? They get confused. So what food I need to take? You told me that you go home and take healthy diet. What does it mean? And very often we give dietary prescription based on very Western concept, and that doesn't apply to our Indian food. And what kind of dietary advice do we give them, which is very Indian? So that's very critical. Coordination and plan ongoing care. Suppose something goes wrong in the home, whom do I call? Do I have a phone contact with somebody in the team, with the multidisciplinary team, whom I can call if there's a crisis at home? Where do I come if I need to come to the hospital? Do I have to come to the emergency, or can I come to your department? So this kind of care plan is very important when you talk about patient-centric care. And other information which they may require regarding access to clinical, social, physical, financial support on continuing basis. You told me that go home and take exercise. So whom do I contact? Where is the physiotherapist support which I have? You told me that because I'm paralyzed, I may get some financial benefit. Whom do I contact to get that financial aid? So what is this? Is there any NGO which can support my father with this kind of condition? So these are things which they need a lot of information. So if they can get that, that makes it complete when you talk about patient care. The last and the most also very important is access to care. They need to know, like I said, where can I get access if there's something, if I need something. Access to location of the hospital, clinic, or physician offices. Suppose I'm going home now, but this hospital is very far. If something happens, which is the nearest place where I can access if I need support? How do I come to you now? How do I schedule an appointment with you? If I need to see the neurologist again, how will I make that appointment? Where do I come now? And also when they get discharged, what is the next scheduled date? When to come, where to come, whom to meet. So all this it's needed to be there in the care plan. When you see a patient with some sickness and you decide to treat the patient, we need to have, I said, all of us, you have to think about all these components of aspect of care plan, which should be there in the care plan. Coming back to this patient, the same patient, advanced COPD, 68 years. What would mean a patient-centered care to this gentleman? When you say the same patient, this patient would expect, or the family, both patient and the family, adequate symptom control. The reason they came to the hospital is the patient was extremely dyspneic. With this kind of circumstances, what is the best symptom control the patient can get? This is a progressive disease, COPD. What kind of communication has happened with the patient and with the family? And was there a shared decision making as to goal of care, which is being planned for this patient? Was there advanced care planning based on patient's value, wishes, and preferences? Advanced care planning as regard to whether in future crisis like this, will he go for mechanical ventilation? Will he go for DNR? Does he need more antibiotics? Shall we just opt for non-invasive method of care? Shall we opt for palliative care? These are the various things which you can think about when you say advanced care planning based on patient's preferences. How about patient's autonomy? Did we ask the patient what is that he wants in terms of his care? What about his psychosocial and spiritual needs? Was it addressed appropriately? And was there a care coordination? If the patient decides that I don't want to come to the hospital, I've enough of this hospital, I want to be in my home. If that is the option he has chosen, and he says, please give me comfort care. So which is the nearest palliative care program this patient has? Can I link him to that program so that he continues to get care in the home? So that makes it complete, because most of these chronic conditions, chronic life-limiting conditions, you're expecting that the disease is going to progress, and at some point of time there will be decline and he may die. If that is the situation, how do we help him with best supportive care, which is based on his values, preferences, and wishes? That makes it the patient-centric care. Thank you.